Hello, this is Dr. Stanley Kim. Currently, I'm working at Good Samaritan Medical Center near Denver, Colorado. It's nice to watch the snowy mountain every day. Today, we will discuss breast cancer. As we know, breast cancer is the most common cancer in women. About 300,000 women will be diagnosed with breast cancer this year. The research in the field of breast cancer is very active in search of better diagnosis, treatments, and prevention. I'm presenting here the most updated information about breast cancer which developed for the last couple of years. I hope this information helps patients and their family have a confidence in their treatments. And also, I hope it helps healthcare providers to provide a better breast cancer care for their patients. Thank you for watching. The breast cancer is so common in the US. 1 out of 8 women will develop invasive cancer in their lifetime. Mammogram is used for screening, and the ultrasound helps it often distinguish benign from malignant lesions. MRI is typically used to screen high-risk women, but there are other indications of MRI, which we will discuss later. There are several different types of breast cancer. Please look at this picture. Breasts are comprised of milk-producing lobules and the milk-draining ducts. Rest of them are mainly fat tissues. When cancer develops from the milk-draining ducts, ductal cells, is called invasive or infiltrating ductal carcinoma, which is most common. When the cancer develops from the lobules, it's invasive or infiltrating lobular carcinoma. Ductal carcinoma in situ, DCIS, arises from the ducts and it's a non-invasive cancer. Lobular carcinoma in situ develops from the lobules and it's non-invasive, but it's not considered as a cancer anymore. It's considered as a high-risk tumor for cancer. Paget disease is kind of a characteristic. It cause some scaly or rash in the nipple or areola. Cancer found in 85% of Paget disease, mostly HER2 positive tumors. Phyllodes tumor, sarcoma, lymphoma are rare. Special subtypes like a mucinous tubular or cribriform breast cancers have a better prognosis. You may see the molecular subtypes of breast cancer in the pathology report, mainly used in research: luminal A, luminal B, HER2 enriched, and basal subtypes. Many people confuse that HER2 enriched subtype is HER2 positive, but actually not. About half of HER2 enriched tumors have a HER2 positivity. Breast cancer screening for average risk women is somewhat controversial. For example, U.S. Preventive Service Task Force recommends the screening starts at age 50 until 74 with a mammogram every 2 years. And for women age 75 or older, no screening is recommended. However, American Cancer Society recommends screening begins at age 45 till 54 with an annual mammogram. For women age 55 or older, every 1 to 2 years, and continue as long as life expectancy is 10 years or more. Breast exam or self-exams are not included in the screening as there is no evidence of benefit. 3D mammogram is better than 2D, especially in dense breast. But we have no discrepancies in high-risk women who needs yearly MRI and the mammogram starting at age 30s. Who are those high-risk women? Patients who have BRCA1 or 2 mutations or their first-degree relative, who have history of radiation to the chest wall when young, who have genetic syndromes like a Li-Fraumeni syndrome, Coden syndrome, or personal history of ductal carcinoma in situ, lobular carcinoma in situ, atypical ductal hyperplasia, and the atypical lobular hyperplasia, or calculated breast cancer risk is over 20% in their lifetime. Patients having extremely or heterogeneously dense breasts shown in mammogram needs to have a yearly breast MRI and mammogram, but not for average risk women with a just dense breast. They just need to have a mammogram and ultrasound every year. What if a woman had a breast implant? They need to have a 4-view mammogram, but not the implant after mastectomy, because mastectomized patients have no breast tissue to screen. Breast MRIs are much more commonly used nowadays. Basically, I like to mention that these breast MRIs are so sensitive, you can detect any small lesions. But on the other hand, it picks up everything. So it has a high sensitivity, but limited specificity. What are the indications when mammogram cannot assess the tumor extent? For example, very heavy, dense breast, or when there is discrepancy between mammogram and the clinical exam. For example, you can feel the lump in the breast, but mammogram doesn't show anything. Then MRI may find some tumors in the breast. When patients present with the axillary lymph node metastasis and there is no tumor in the breast palpable by exam or shown in mammogram, then MRI may pick up the occult primary tumor. Or when chest wall or muscle invasion by cancer is suspected. For locally advanced breast cancer, MRI is done to evaluate before or after neoadjuvant chemotherapy, which means giving a treatment before surgery to shrink it, before bilateral mastectomy or reconstruction, and the Paget disease with a negative mammogram, and to screen high-risk women we already discussed in the previous slide. For patients who have BRCA mutations, they have a high risk of breast cancer, so you always want to do the MRI to detect any cancer in the other side of breast or even the same side of breast. When you suspect a silicone implant rupture, then MRI has to be done. But saline implants is not helpful because MRI won't pick up the saline. The MRI should be avoided during ovulation or luteal phase because the breast tissues is influenced by hormone. So the MRI should be done during the menstrual cycle days between 5 to 15 days and avoid during lactation. Previous surgery or radiation therapy may increase gadolinium contrast uptake, resulting in false positive studies. On the other hand, hormone therapy like tamoxifen, aromatase inhibitors may cause false negative studies. Because it's so sensitive, it can pick up even benign lesions like a fat necrosis, so false positive rate is high and the specificity is limited. Please look at this MRI of the breast picture. I like to introduce newly developed imaging studies. Fluoroestradiol F18 PET scan called the Seriana. It detects estrogen receptor positive lesions in patients with recurrent or metastatic disease. When patients develop new metastatic lesion, biopsy is usually recommended to check the estrogen, progesterone receptors, and the HER2 status, because those biomarkers of metastatic disease may be different from the primary tumors. However, not all metastatic lesions are accessible for biopsy because of difficult locations. Then fluoroestradiol F18 PET scan can detect those estrogen receptor positive lesions. And after the hormone therapy, you see it shrinking here. It's not sensitive when patients are taking tamoxifen or fulvestrant, but aromatase inhibitors are okay. The reason is tamoxifen and the fulvestrants are directly affects the estrogen receptors, but not the aromatase inhibitors. Contrast enhanced digital mammogram. It's somewhat complementary to MRI. It's less sensitive but more specific than MRI. It may use in equivocal case in mammogram and for assessment of tumor extent preoperatively and the post-neoadjuvant therapy response. It is also can be used for screening for high-risk women as an alternative to MRI. Please look at these pictures. Contrast-enhanced mammogram can pick up those small cysts and inflame the cyst. And the MRI picture is almost the same. Breast biopsy can be done by stereotactic breast biopsy using mammography machine or ultrasound-guided breast biopsy, or by MRI-guided biopsy using MRI machine here. With a biopsy specimen, pathologist will determine what kind of breast cancer it is and also test for cancer biomarkers, which include estrogen receptor, ER, progesterone receptor, PR, and the HER2. ER, PR positive breast cancers are most common and have a better prognosis, can be treated with endocrine therapy. HER2 positive breast cancer or HER2 overexpressed breast cancer counts for 20% of all, have a poor prognosis, but can be overcome by treatment with HER2 inhibitors like Herceptin. ER, PR, and the HER2s are all negative. Those are triple negative breast cancer, account for 15 to 20%, have a poor prognosis. But with a neoadjuvant chemotherapy, which is given before surgery, prognosis can be improved. About 20% of triple negative breast cancers are BRCA positive tumor, and the majority of BRCA1 positive are triple negative breast cancer. So all patients with a triple negative breast cancer need to have a BRCA testing. Pathologists also grade the tumor into low grade, grade 1, intermediate, grade 2, and the high grade, grade 3. Some patients need to have a BRCA genetic test, and often we include the other related gene mutations such as PALB, CDH1, PTEN, etc. When the pre-imaging early stage breast cancer, like a stage 1 or 2, then CT scan or bone scans are not necessary unless clinically suspicious for metastasis. For example, the tumor is small but patients complain of headache or bone pain, then you may have to order the bone scan or even MRI scan of the brain. If the bone metastasis is strongly suspected and the nuclear bone scan is negative, MRI to the area is indicated to make sure there is no bone metastasis. But when the patients have advanced stage, clinical stage, then metastatic workup with a CT scan of the chest, abdomen, pelvis, and the nuclear bone scans are indicated. And the PET-CT scans are often done if metastasis is strongly suspected. HER2, human epidermal growth factor receptor 2, is an intracellular tyrosine kinase produced by HER2 oncogenes. The overexpressed HER2 caused by HER2 gene amplification promotes the cancer cell growth, but HER2 inhibitors like Herceptin block HER2 and decrease recurrence and improve survival rates when used for HER2 positive cancers. HER2 inhibitors do not have any effect on HER2 negative cancers. American Society of Clinical Oncology issued the guideline for HER2 test in 2018, which was modified from previous edition, and I think it's still evolving. HER2 positive is defined by 3+ in IHC stain in 10% or more tumor cells. IHC stands for I, immuno, H, histo, C, chemical studies. HER2 negative is when IHC is 0 to 1+. When IHC is a 2+, it's equivocal. Equivocal study requires the fish conformation. Look at this HER2 fish, the pictures. In this nucleus, we have a pair of chromosomes, one from father, one from mom. And the HER2 gene is located in chromosome 17. And because of pair of chromosomes in the nucleus, we expect to see two HER2. It's a red dot, it's a fish probes. As a control, centromere of chromosome 17 is used. It's green dots. The probe is green dots. So normally we expect that two HER2 and two centromeres in a cytoplasm. But when the HER2 is amplified by maybe aneuploidy chromosome, instead of pair chromosome, maybe 3 chromosomes, 4 chromosomes, the number of HER2 will be increased like this nucleus. I think 1, 2, 3, 4, 5, 6. But the control centromere is a pair 2. So in this case, this is positive HER2 because the HER2 copies number is 6 or more. On the other hand, the ratio of HER2 and the centromere is also used to define HER2 positivity. When the ratio of HER2 in relation to centromere is 2 or above, it's a positive. There are two types of staging system in breast cancer. Anatomical staging using TNM system, and the other prognostic staging, which include the tumor grade and the biomarker status. TIS means carcinoma in situ, like a ductal carcinoma in situ. T1, tumor size is 2 cm or below. T2, size between 2 to 5 cm. T3, bigger than 5 cm. T4, tumor invades the chest wall or skin or both. When cancer is inflammatory breast cancer, it's T4D. N stands for nodes, lymph nodes. N1 means there are 1 to 3 lymph node metastases. And N2, 4 to 9 lymph nodes. N3, 10 lymph nodes, 10 or more lymph nodes metastasis. The few things, if the patients have supraclavicular lymph node metastasis in the same side, it's N3C. In anatomical staging, stage 1 means tumor size 2 cm or below without lymph node metastasis. Stage 2, size is bigger, 2 to 5 cm or lymph nodes up to 3 lymph nodes metastasis. Stage 3, tumor size is bigger than 5 cm or multiple lymph node metastasis. And the stage 4 is a metastasis to distant organs. The anatomical staging and the pathological prognostic staging may be different. For example, here, when the tumor is T1 and N0, no lymph node metastasis, and if it's a grade 2, the intermediate grade, and if it's HER2 negative and the estrogen receptor ER is negative and the PR is negative, it's triple negative, it's stage 1B. Otherwise, if you don't consider this ER, PR, or HER2, anatomical stage is going to be 1A. The prognostic staging, I think it reflects more accurate prognosis of breast cancer. To remove cancer from the breast, either mastectomy or breast conserving therapy is used, and both are equally effective. Breast conserving therapy consists of lumpectomy,
followed by radiation therapy to the remaining breast. But not every woman can have a breast-conserving therapy. The indications of mastectomy include multicentric tumor, which means the cancer locates in different quadrants of breast. Inflammatory breast cancer always requires mastectomy. Diffuse suspicious microcalcification suggestive of cancer spread out in the whole breast need to have a mastectomy. Large tumor size relative to breast size actually need to have a neoadjuvant therapy to shrink the size of tumor before surgery so the patients can have a breast conserving therapy. Connective tissue disease increased late radiation toxicity, especially lupus or scleroderma. Other connective tissue diseases are mostly well tolerated, like a rheumatoid arthritis. When patients have a previous radiation to the same chest, then you can't give any more radiation. Pregnancy needs to avoid radiation. When patients have persistent positive margins despite re-excision, 2-3 times of lumpectomy, then mastectomy is necessary. Patients with a positive BRCA, usually unilateral or bilateral prophylactic mastectomies are preferred because their chance of cancer coming back in the same or different breast are very high. But still they can have a breast conserving therapy if they choose and take the risk. Most women undergo sentinel lymph node biopsy during surgery. Please look at this picture. Sentinel lymph nodes are the closest lymph node from the primary breast tumor. Surgeon inject the blue dye or radio tracer about an hour before surgery. And during surgery, he or she cut open this armpit to look for the sentinel lymph nodes. By looking at the bluish colored lymph nodes, or lymph nodes have a radioactivity detected by gamma camera. But not all patients need to have a sentinel lymph node biopsy. Patients have palpable lymph node metastasis already. We know they have a lymph node metastasis. Then they don't need to have a sentinel lymph node biopsy. They just need to have an axillary lymph node dissection. When patients have a non-invasive tumor like a DCIS, ductal carcinoma in situ, when the chance of lymph node metastasis is very low, don't need to have a sentinel lymph node biopsy. However, patients who have a DCIS who decided to have a mastectomy need to have a sentinel lymph node biopsy because once the mastectomy is done, it disrupts the lymph node lymphatic system of the chest wall, and they will never be able to have a sentinel lymph node biopsy. During pregnancy, certain blue dye is teratogenic. However, the small dose of radiotracer alone may be used safely. Inflammatory or locally advanced breast cancer usually need to have an axillary lymph node dissection, so why they need to have a sentinel lymph node biopsy? One thing that I really like to mention is that older patients, age 70 or above, who have clinically negative lymph nodes and the estrogen progesterone positive and the HER2 negative may forego sentinel lymph node biopsy because there is no survival difference between the patients who had a sentinel lymph node biopsy and who didn't. I'd like to mention about infiltrating lobular carcinoma briefly. As we know, invasive or infiltrating lobular carcinoma arise from the milk-producing lobules. They are more bilateral and multicentric than ductal carcinoma, but patients still can be managed by breast-conserving therapy. More common in elderly women, more likely estrogen receptor positive. It's associated with a hereditary diffuse gastric cancer, which is caused by germline CDH1 mutation. And this infiltrating lobular carcinoma occurs in 20 to 50% of family member of hereditary diffuse gastric cancer. So when you have a patient with this infiltrating lobular carcinoma, please look for any family history having a gastric cancer. If they do, then you need to check for the CDH1 mutation to rule out hereditary diffuse gastric cancer. Many women undergo breast reconstruction after mastectomy, either by using implant, silicone or saline implant like this picture, or using tissue flap, transplanting that tissues to the breast like this. Immediate reconstruction provides better protection from psychological distress or poor body image than delayed reconstruction. But not every woman can have an immediate reconstruction. The contraindications are inflammatory or locally advanced breast cancer, when need of post-mastectomy radiation therapy. You can't radiate this implant because it will be damaged by radiation, or when the patients have a lot of other medical conditions. Aesthetically, bilateral mastectomy achieves better symmetry, but for unilateral mastectomy, a reduction mammoplasty or breast lift can make it balanced with the other breast. Skin-sparing mastectomy or nipple areola-sparing mastectomy is usually performed with the immediate reconstruction. And the local recurrence rate is almost same as total mastectomy, so it's become more popular. For implant, a permanent implant is inserted above or under the pectoralis muscle during the mastectomy, but sometimes tissue expander is placed first and then gradually expands by filling normal saline, then replace it with a permanent implant later on. For tissue flap reconstruction, most commonly used type is deep epidermal artery perforator flap, DIEP flap, or TRAM, the transverse rectus abdominis musculocutaneous flap. DIEP flaps, you can see that the part of the lower abdomen tissues are transplanted to the skin-sparing mastectomy space with this artery and the veins, which is connected to internal mammary artery and vein. Tram flap, you use the muscles and the other tissues and directly transfer to the mastectomy area, and then is connected to the breast artery and the veins. Adjuvant therapy is a treatment given after surgery, hoping to eradicate any remaining cancer cell in the body. Depending on the hormone receptor and the HER2 status, the types of adjuvant therapies are different. Let's discuss adjuvant therapy for hormone receptor positive and the HER2 negative breast cancer, which is the most common type. When patients have a negative lymph node metastasis and the size of tumor is small, less than 1 centimeter, low-grade tumor, endocrine therapy alone is sufficient without chemotherapy. But when the size of tumor is 1 centimeter or bigger, then Oncotype DX is very useful. This Oncotype DX provides the recurrence score. The higher the recurrence score, the higher the risk of recurrence. When the recurrence score is a 15 or lower, then chemotherapy is not required, not necessary. When the recurrence score is a 26 or higher, then chemotherapy is given along with the endocrine therapy. What if the recurrence score falls in between 16 to 25? Then depending on the age of the patient. When they are older than 50 years and postmenopausal, then endocrine therapy alone is fine. When the age is 50 years or younger, premenopausal, then you subdivide the recurrence score to two groups, 16 to 20 and 21 to 25. When the recurrence score belongs to 21-25, then chemotherapy is necessary along with the endocrine therapy. However, when the recurrence score is 16 to 20 and the tumor has a low risk features, then endocrine therapy alone is sufficient. What are those low risk features? Those are if the tumor is less than 3 centimeters, then grade 1. If the tumor size is less than 2 centimeters, in the grade 2. And when the tumor is very small, less than 1 centimeter, then grade 3 is allowed as a low risk feature. Interestingly, the benefit of chemotherapy is mostly seen at age group 45, close to postmenopause, and the less with a younger age, indicating the chemotherapy-induced postmenopausal status is the reason why chemotherapy was effective. So some experts recommend endocrine therapy with ovarian function suppression instead of chemotherapy. What do you think? I think it makes sense. When the patients have a lymph node positive disease, then again Oncotype DX is used. If the number of lymph nodes is 4 or more, those are very high risk. They, of course, need to have chemotherapy along with endocrine therapy. Or when the recurrence score is a 26 or higher, again, they need to have a chemotherapy and endocrine therapy. But if the number of lymph node metastasis is 3 or less, and the recurrence score is a 25 or lower, then depending on the menopausal status, for postmenopausal women, endocrine therapy only is sufficient. However, for premenopausal women, they need to have a combination of chemotherapy and endocrine therapy. For those high-risk premenopausal women, ovarian function suppression is necessary. It can be achieved by drugs injections or removal of both ovaries surgically, and always combined with the aromatase inhibitor or tamoxifen. When this ovarian function suppression is combined with the aromatase inhibitor, it actually showed a better 5-year survival rate than when combined with the tamoxifen, but there was no difference in mortality rate. For very high-risk patients, like a lymph node metastasis 4 or more, or if it's 1 to 3, high-grade tumor or tumor bigger than 5 centimeters, then abemaciclib for 2 years, in addition to the chemotherapy and the endocrine therapy, improved the 3-year disease-free survival. And the FDA approved, regardless of menopausal status. For endocrine therapy, there are 2 groups of drugs, either tamoxifen or aromatase inhibitors. Aromatase inhibitors have 3 drugs available: anastrozole, arimidex, letrozole, femara, exemestane, aromacin. Aromatase inhibitors block estrogen production by inhibition of aromatase in peripheral tissues such as adrenal gland, but they do not block estrogen synthesis in ovary. So it's only effective in postmenopausal women who have no ovarian function. The side effects are more prominent. Aromatase inhibitor associated musculoskeletal syndrome occurring in about 30% of patients. Patients complain of a lot of pain in the body, like a bone, joint, muscles, and the highest with the anastrozole. How you treat those pain by exercise or switching to different aromatase inhibitor drugs or to tamoxifen. Cymbalta often helps to relieve the pain. Bone loss is an important side effect. So when the patients have osteoporosis or risk of fractures high, the oral or IV bisphosphonate, like a Fosamax oral or Zomida IV or Prolia denosumab injection every 6 months can be given. They also can cause hypercholesterolemia, ischemic heart disease, depression, vaginal dryness, insomnia, hair loss, and even diabetes. So about 7% of patients discontinue aromatase inhibitor due to side effects. Tamoxifen is well known and it has a less side effect compared to aromatase inhibitor. It is selective estrogen receptor modulator. It's antagonist of estrogen receptor. So it can be used for both premenopausal and the postmenopausal women. The side effects are different. It can cause blood clots and increase stroke risk, but it is cardioprotective. Uterine cancer risk is higher in elderly patients age 55 or above. It can also cause fatty liver, hot flash, diabetes, hair loss, vaginal discharge, or sometimes dryness. There are drug interactions with mostly antidepressants. because those antidepressants like a Prozac, Wellbutrin, are cytochrome P45 inhibitors. So you cannot use tamoxifen when the patients must take Prozac or Wellbutrin. However, the Effexor or Celexa are weak inhibitor and they can be used. Now let's discuss endocrine therapy for postmenopausal patients more in detail. In general, aromatase inhibitors is preferred over tamoxifen because aromatase inhibitors are better than tamoxifen in reducing recurrence and improving mortality rate. The duration of therapy is minimum 5 years and extending to 2 to 5 more years in high-risk patients improve the recurrence-free survival rates. But recently, extending to 2 to 3 more years, which means total 7 to 8 years, is as good as extending to 5 years, which is 10 years of therapy. When the patients suffer from the side effects, you may stop for a while and without any harmful effect. The study have shown that 9 years in a year was as effective as continuous treatment 12 months at a year. I have a question for you. When the patients had 5 years of aromatase inhibitor, would you continue aromatase inhibitors for 2 to 3 more years or switch to tamoxifen? The answer is the same. Either tamoxifen or aromatase inhibitor had a same efficacy. Now, another question. When the patients have been taking tamoxifen for 5 years, and would you switch to aromatase inhibitor or continue tamoxifen? In this case, switching to aromatase inhibitors may be slightly more beneficial. Between aromatase inhibitors, patients may switch to another aromatase inhibitors without any harmful effect because there is no difference in efficacy. In general, the anastrozole and the letrozole have cause more hypercholesterolemia, and exemestane has more GI side effects. As I mentioned earlier, FDA approved abemaciclib, Verzenio, for higher risk patients who have lymph node metastasis 4 or more, or with a high grade or T tumor size 5 cm or more, and the Ki-27 index 20% or more. Endocrine therapy can be started with adjuvant radiation therapy or after radiation therapy, and also can be given together with adjuvant and anti-HER2 inhibitors like Herceptin. Now, endocrine therapy for premenopausal patients. High-risk patients need to have ovarian function suppression. Who are those high-risk patients? Patients requiring chemotherapy, like a positive lymph node metastasis, large tumor 5 cm or bigger, high oncotype DX, recurrence score 26 or higher, or younger patients, age 35 or younger. They need to have ovarian function suppression, which can be achieved by drug injections, gonadotrophin releasing agonist, like a leuprolide, Lupron, Goselarin, Zoladex injection, monthly injection, or by surgical removal of both ovaries. This ovarian function suppression is always combined with either aromatase inhibitor or tamoxifen, preferably combined with the aromatase inhibitor because it reduces the recurrence rate better than when combined with the tamoxifen. But survival rate was not different, so either one is fine. When the patients have a higher risk, like a lymph node metastasis number 4 or more, or if it's 1 to 3 lymph node metastasis, then the grade is 3, high grade or bigger tumor, 5 cm or bigger. Then abemaciclib, Verzenio, for 2 years of adjuvant therapy improved the 3-year disease-free survival, and it's approved by FDA. Aromatase inhibitor may activate ovarian function in premenopausal who achieve the postmenopausal status clinically. In other words, you have a premenopausal woman who had a chemotherapy and then induced the amenorrhea and you think, oh, the patient now is in postmenopausal, so aromatase inhibitor is fine. So you start the aromatase inhibitor, boom, they have a period again, which means they are not truly postmenopausal status. So always check the FSH, LH, and the estradiol levels to make sure patients is in true postmenopausal status before you start the aromatase inhibitor. Because in this case, the prognosis is different, it's worse. So you may just use tamoxifen during this period when you are not sure until the true postmenopausal state is achieved. Then tamoxifen can be switched to the aromatase inhibitor or ovarian function suppression test. For the low-risk patients who do not need to have a chemotherapy or older than age 35, tamoxifen monotherapy alone is sufficient without ovarian function suppression. When the tamoxifen alone is compared with the ovarian function suppression test, suppression combined with tamoxifen or aromatase inhibitor, there was no difference in 12-year survival. They achieved 95% disease-free survival in the text clinical trial. What about the duration of endocrine therapy in postmenopausal patients? At least 5 years with options of extended therapies like a postmenopausal patient. If the premenopausal status continues after chemotherapy, ovarian function suppression is recommended along with the tamoxifen or aromatase inhibitor rather than tamoxifen alone. But some patients do not tolerate the ovarian function suppression, like drug injections, Zoladex injection. Then it may be shortened to 2 years instead of full 5 years. Tamoxifen is a teratogenic, so should not use before or during pregnancy. And at least 2 to 3 years of contraception is required prior to attempting pregnancy after cessation of tamoxifen. Adjuvant chemotherapy is usually used for high-risk breast cancer because it improves recurrence and the survival rates. But most small tumors, size 0.5 centimeter or smaller, do not need adjuvant chemotherapy as benefit is low and toxicity is high. We have studied indication of adjuvant chemotherapy for hormone receptor positive patients. Briefly, patients who have many lymph node metastases or oncotype DX recurrence score is high, 26 or above. Premenopausal patients who have a lymph node positive, even though recurrence score is less than 26. Premenopausal patients who have a negative lymph nodes metastasis, but as long as they have a recurrence score is 21 to 25 or high risk features. Triple negative breast cancer patients need to have adjuvant chemotherapy as long as the size of tumor is bigger than 0.5 centimeter or when they have a lymph node metastasis. But in this case, neoadjuvant chemotherapy before surgery is preferred over adjuvant chemotherapy. For patients who have a BRCA mutation positive and the high risk, benefit from olaparib, which is PARP inhibitor given for 1 year, which improved the 3-year disease-free survival. It's recently approved by FDA. What are the commonly used chemotherapy regimen? Most commonly, dose-dense ACT, doxorubicin, cyclophosphamide for 4 cycles, followed by paclitaxel for 4 cycles in a 14-day cycle. Is better than classic ACT, which is given every 21 days. But for low-risk patients, milder regimen with a TC, Taxotere, docetaxel, and the cyclophosphamide every 3 weeks for 4 cycles only is sufficient. So total 3 months of chemotherapy. More recently, a randomized study showed that this milder TC regimen is not inferior to the classic ACT regimen as long as it's given for 6 cycles. High-dose chemotherapy and autologous stem cell transplantation is not recommended because there is no survival benefit. When to start adjuvant chemotherapy? usually starts 4 to 8 weeks after surgery, but never after 12 weeks because it impacts the overall survival negatively. Chemotherapy benefits have not studied much in elderly patients, but age itself shouldn't be the reason in deciding treatment. Overweight patients need a no initial dose adjustment. Now, HER2 positive breast cancer. HER2 positive breast cancers are usually treated with a neoadjuvant therapy given before surgery, but adjuvant therapy is given when upfront surgery is done for early stage disease. It's indicated as long as the tumor size is 0.5 centimeter or larger. Some experts give adjuvant therapy even for smaller tumor size 3 to 4 millimeter when hormone receptors are negative. For smaller sized tumor less than 2 or 3 centimeter and the negative lymph node, paclitaxel single chemotherapy weekly for 12 cycles taking 3 months with a 1 year of trastuzumab Herceptin improved the overall survival by 40%. Now the trastuzumab Herceptin can be given subcutaneously. For larger sized tumor bigger than 2 centimeter or positive lymph node metastasis, in those cases usually neoadjuvant therapy is recommended, but when the upfront surgery was done, pertuzumab Perjeta is added to Herceptin and given concurrently with the chemotherapy such as TCHP, taxotere carboplatin, or ACT. Neratinib, a PARP inhibitor, followed by trastuzumab Herceptin for 1 year, may be used especially for estrogen receptor positive patients. But when the patients receive the Perjeta, you don't actually add a neratinib because combined pertuzumab and the neratinib are not useful. There is no benefit. Pertuzumab improved the 6-year invasive disease-free survival in positive lymph node patients, but not for negative lymph node patients. Even the tumor size is 3 or 4 centimeter. Combination of pertuzumab and the trastuzumab is given subcutaneously nowadays it sells under the name of Phesgo. Trastuzumab Herceptin is a cardiotoxic which is reversible. In other words, when you stop Herceptin, the cardiac function improves. So baseline echocardiogram needs to be done at 3, 6, and 12 months. A recent study showed that 6 months of Herceptin was not inferior to full 12 months of therapy, especially when patients were treated with ACT. But patients who have negative ERPR receptors, 12 months is better than 6 months. We know adjuvant chemotherapy is chemotherapy after surgery, and the neoadjuvant chemotherapy is chemotherapy given before surgery. Why? To shrink large tumor to make it resectable for breast conserving therapy. And when the tumor is completely gone after neoadjuvant chemotherapy, which means pathological complete response, indicate improved survival in triple negative breast cancer. But this pathological complete response is rare in hormone receptor positive breast cancer. It's high, like a 40 to 60% in case of triple negative or HER2 positive breast cancer. And for residual disease after neoadjuvant chemotherapy, certain treatments can improve outcome. Mostly chemotherapy is used, but we'll also add a HER2 inhibitor like Herceptin for HER2 positive disease. But sometimes neoadjuvant endocrine therapy may be used for strongly positive estrogen receptors and the low Ki67 or frail patients for chemotherapy. For postmenopausal patients, aromatase inhibitor is preferred over tamoxifen because of higher response rate, 60% versus 40%. So the indication of neoadjuvant chemotherapy include locally advanced breast cancer or inflammatory breast cancer. For early breast cancer, we use neoadjuvant chemotherapy for triple negative disease when the size of tumor is bigger than 1 centimeter, or HER2 positive disease when the size bigger than 0.5 centimeter. But ASCO guideline suggests tumor bigger than 1 centimeter. And when the breast size is small and the relatively size of tumors are bigger, so when good cosmetic outcome of breast conserving therapy is not possible, then neoadjuvant chemotherapy is given to shrink the tumor. For some reason, surgery is delayed. You don't want to wait too long, then you give a chemotherapy first. It's very important to check the axillary lymph node status before neoadjuvant chemotherapy. When you don't feel obvious clinical metastatic disease in the axillary lymph nodes, always order ultrasound of axilla. If there is suspicious lesion, then fine needle aspiration or biopsy, and the place of a metal marks or marks is necessary. And this lymph node biopsy was negative, then proceed neoadjuvant chemotherapy and do central lymph node biopsy during surgery. If it's a positive, then patients need to have an axillary lymph node dissection. If it's negative, then no dissection. Before neoadjuvant chemotherapy, the ultrasound guided biopsy, lymph node biopsy is a positive, then still proceed neoadjuvant chemotherapy and do the central lymph node biopsy and remove the marked lymph node. If it's positive, still there is a cancer, then patients need to have an axillary lymph node biopsy with or without radiation therapy. We don't know exactly what is the best, awaiting clinical trial results if less treatment is enough. If the central lymph node biopsy is negative, then no lymph node bisection. But make sure that central lymph node biopsy contained marker lymph node. If didn't contain it, then you never know. So you have to do axillary lymph node biopsy or radiation therapy. For obvious advanced lymph node metastasis before neoadjuvant chemotherapy or after neoadjuvant chemotherapy still have a N1 positive lymph node metastasis, then patients need to have an axillary lymph node dissection with a radiation therapy. The neoadjuvant chemotherapy regimens are similar to those used for adjuvant chemotherapy. Again, dose-dense ACT, adriamycin with a cyclophosphamide followed by paclitaxel, especially for high-risk patients. But for intermediate or low-risk hormone receptor positive HER2 negative patient, milder regimen TC, taxotere with a cyclophosphamide for 4 to 6 cycles is a good alternative. Triple negative breast cancers are treated a little bit differently. Usually carboplatin is incorporated to ACT regimen because when you add carboplatin, it improves the pathological complete response rate and the disease-free survival. But it didn't improve 5-year overall survival, so it's a little bit arguable. Taxotere plus carboplatin every 3 weeks for 6 cycles result in same pathological complete response rate. So it's a very good alternative when patients have a heart issue because adriamycin is cardiotoxic. For stage 3 or 2 or 3 triple negative breast cancer, pembrolizumab Keytruda improved the disease-free survival when it's incorporated into chemotherapy. It's published and the FDA approved recently. For residual disease after neoadjuvant chemotherapy, capecitabine 2 weeks out of 3 week cycle for 6 to 8 cycles improved disease-free survival and overall survival in HER2 negative breast cancer. Especially triple negative breast cancer patients have a more benefit. For BRCA positive patients who have a residual disease after neoadjuvant chemotherapy, olaparib, the PARP inhibitor for 1 year after neoadjuvant chemotherapy improves disease-free survival and is approved by FDA recently. For HER2 positive disease, like adjuvant chemotherapy, patients receive the HER2 inhibitors like Herceptin for a total of 12 months. And recent studies show the 6-month therapy may be okay for lower risk patients like a estrogen receptor positive patient. The regimen used for HER2 positive disease is TCH with or without P. Those are Taxotere, carboplatin, and Herceptin with or without pertuzumab, Perjeta. After surgery, Herceptin is continued for a total of 12 months. You can use weekly paclitaxel, carboplatin, and the Herceptin with or without pertuzumab for 18 weeks. But again, the Herceptin or Herceptin need to be continued for a total of 12 months. For small tumor, less than 2 centimeters without lymph node metastasis, just simply paclitaxel and the Herceptin every week for 12 weeks is sufficient. It's very important to know that for residual disease, for HER2 positive breast cancer, adotrastuzumab emtansine, the trade name is Kadcyla, every 3 weeks for 1 year, 14 cycles, lower the invasive disease-free survival rate and the mortality rate by 50%. Adjuvant radiation therapy is part of the breast conserving therapy given after lumpectomy. Radiation therapy is given to whole breast after lumpectomy for 3 to 4 weeks in a hypofractionated dosage instead of traditional 6 to 7 weeks. Not everybody needs to have a radiation therapy after lumpectomy. Elderly patients age 65 or older with a smaller tumor, 3 centimeter or smaller, low grade, grade 1 or 2, negative lymph node metastasis, or and ER positive, HER2 negative, who will have endocrine therapy after lumpectomy may omit radiation therapy without any harmful effect. I like to mention accelerated partial breast irradiation. It's a focused radiation to a limited area of concern with a higher dose per fraction in a short period of time. So the duration of radiation can be shortened greatly. It's indicated for postmenopausal women who have a smaller tumor with a negative lymph node metastasis and a negative surgical margin, but it's not indicated for BRCA positive patients, triple negative, HER2 positive, lobular carcinoma, or grade 3 ductal carcinoma in situ. The way to giving accelerated partial breast radiation is by conformal external beam radiation therapy. Look at this picture. It's given twice a day for 5 days or daily for 2 weeks, or by interstitial brachytherapy. Look at this picture. Interstitial brachytherapy, the cannula is inserted to the breast tissue of concern and they insert the radioactive seeds into the area. Or by intracavitary brachytherapy, the cannula is inserted to the area of concern and they inject the radioactive fluid to make a balloon here to radiate in this area. This accelerated partial breast radiation has the same overall survival of the same as the traditional whole breast radiation therapy, but cause less radiation toxicity and improve cosmetic outcome. Now, sometimes radiation therapy is given to regional lymph nodes like internal mammary, infra or supraclavicular area, as well as to axillary lymph nodes. For those patients who have many axillary lymph nodes, because they have a higher risk of recurrence, or a bigger tumor, T3 or T4, or maybe for smaller tumor, T2, with a high risk features like a lymph node metastasis with extra capsular extension, or total number of dissection is less than 10, or high-grade tumor, or triple negative breast cancer. Radiation therapy to the chest wall and the local regional lymph nodes can be given after mastectomy when the patients have a higher risk features like many lymph node metastasis, 4 or more, or tumor size is bigger than 5 centimeters. After axillary lymph node dissection, radiation therapy is usually not given to axilla because of increased lymphedema. No radiation therapy is necessary for all margin-positive patients. Only for younger patients, premenopausal with a bigger tumor, bigger than T2 or high grade, or lymphovascular invasion. Otherwise, postmenopausal patients who have low-grade tumor and then small tumor may not need to have a radiation therapy for margin-positive breast cancer. Complications of radiation therapy include acute skin toxicity, rib fracture because it radiates the ribs, cardiotoxicity because when you give radiation to the left breast, then the heart is just behind that chest wall. Lung injury and even can cause lung cancer. Secondary malignancy, like a sarcoma, usually occurs in 10 years after radiation therapy, but it's rare. Radiation-induced breast fibrosis can be reduced by pentoxifylline and the vitamin E therapy. Radiation therapy is given before permanent implants because radiation therapy can damage the implants. I like to mention about ductal carcinoma in situ, DCIS, also called intraductal carcinoma. Its incidence is increasing with widespread use of screening mammogram, comprising 25% of all newly diagnosed breast cancers. It's mostly seen as microcalcification of undetermined morphology in mammogram. But mammogram often underestimates the extent. MRI is better, but it's not routinely indicated. For treatment, lumpectomy with the radiation therapy as a breast conserving therapy or mastectomy is used. For lumpectomy, a 2 millimeter surgical margin is required because if the margin is less than 2 millimeter, recurrence doubles to 24%. So often re-excision is done, but decision about re-excision is individually made in a multidisciplinary fashion. Radiation therapy reduces recurrence in the same breast to 9%, without radiation 24%, but not distant recurrence or overall survival rate. So low-risk DCIS may not need radiation therapy to avoid radiation toxicity. Those are smaller tumor, 2.5 centimeter or less, or surgical margin 1 centimeter or more. When you're not sure whether patients need to have a radiation or not, Oncotype DX may be ordered. And when a recurrence score is less than 39, patients may not need to have a radiation therapy. But this is not a standard of care because lack of validation in a randomized studies. Sentinel lymph node biopsy is not routinely done because of very low chance of lymph node metastasis, unless patients will have a mastectomy, because mastectomy disrupt the lymphatics, so patients will never be able to have sentinel lymph node biopsy in the future. For hormone receptor positive DCIS, endocrine therapy for 5 years indicated, with a tamoxifen for premenopausal women, tamoxifen or aromatase inhibitors for postmenopausal women. But when the patients have a prophylactic mastectomy in the other side, bilateral mastectomy, endocrine therapy is not necessary because there is no breast to reduce the risk. Her2 test is not routinely done. Micro-invasive breast cancer is often seen in large and the multicentric DCIS. This is defined as invasion 1 centimeter or less. Lymph node metastasis is very rare in microinvasive breast cancer, 5% or less, but sentinel lymph node biopsy is necessary during surgery. Lobular carcinoma in situ actually is not cancer anymore. So patients with this lobular carcinoma in situ do not need to have a surgery, but just need to have a close observation, surveillance. Except the pleomorphic or florid type of lobular carcinoma in situ. Those are higher risk and they need to have an excision. But if the surgical margin is positive, which is common in lumbar lobular carcinoma in situ, the re-excision is not necessary with the classic lobular carcinoma in situ. But if it's pleomorphic or florid, yes, then patients need to have a re-excision. And the prophylactic mastectomy is not routinely recommended for lobular carcinoma in situ. Inflammatory breast cancer. It's a highly aggressive cancer in the rare 1 to 2% of all breast cancers. Patients almost always have a lymph node metastasis, often distant metastasis at the time of diagnosis. And this tumor is staged as a T4D. Patients have a diffuse erythema and the edema in the breast, having podorange change. It's like orange skin. Please look at this picture. It's one of my patients. You can see the orange skin changes here, involving more than 1/3 of breast skin. Its inflammatory skin changes are due to tumor emboli within the dermal lymphatics. Diagnosis is usually done by clinical skin signs, and all following criteria must be met, which include rapid onset of erythema, edema, and/or podorange, and/or warm breast without palpable mass. Duration of history is less than 2 months or less. Erythema occupying at least 1/3 of the breast. Pathologic confirmation of invasive carcinoma. Very often you do the skin biopsy of the red area, and it will show dermal lymphatic involvement. But the dermal lymphatic involvement is not necessary nor sufficient to make diagnosis in the absence of classical clinical findings. Almost always CT scan of the chest, abdomen, pelvis, and bone scan, sometimes PET CT scan are necessary for investigation for metastatic workup. Treatments usually neoadjuvant chemotherapy with ACT. If the HER2 positive, then add HER2 inhibitors. We discussed in the previous slides. If the hormone receptor positive, then you can add endocrine therapy as an adjuvant treatment. Hopefully, neoadjuvant chemotherapy shrink the tumor. Then patients can have a mastectomy and axillary lymph node dissection. Those patients never need to have a central lymph node, always need to have an axillary lymph node dissection after neoadjuvant chemotherapy, and then give a radiation therapy too. If not resectable after neoadjuvant therapy, then you can give second-line chemotherapy. Then give a radiation therapy to shrink the tumor and hopefully to resect, meaning mastectomy. Prognosis is not too bad with this treatment. 5-year survival, 30 to 70%. Elderly breast cancer patients may be treated somewhat differently from younger patients. Some elderly patients may not need surgery at all. Several randomized studies have shown that patients aged older than 70 or 75 with an estrogen receptor positive and a negative lymph node metastasis showed no difference in 10-year overall survival when they are treated tamoxifen alone without mastectomy when compared with the patients who had a mastectomy and the tamoxifen. So some elderly patients who have underlying medical conditions who are not fit for surgery may be treated with tamoxifen or other aromatase inhibitors without mastectomy. When they need to have adjuvant chemotherapy, milder regimen, Taxotere with a cyclophosphamide for 4 cycles, was well tolerated in age older than 70, but about 50% of patients required granulocyte colony stimulating factor to prevent neutropenia. It's interesting to see that in HER2 positive tumors, when they have a strong positive ER expression, so-called triple positive breast cancer, may not respond well to trastuzumab, Herceptin. Likewise, those HER2 positive tumors, when they have a weak ER expression, don't respond to endocrine therapy well. Nevertheless, NCCN and the ASCO guidelines recommend endocrine therapy for those triple positive tumors, regardless of the degree of estrogen receptor expression, because of conflicting clinical study results. Some elderly patients with HER2 positive tumors, trastuzumab alone, Herceptin alone, without chemotherapy was effective, recently published. Or when they need to have a chemotherapy, just paclitaxel alone with a Herceptin was as effective as more stronger chemotherapy with a Herceptin. And the duration of Herceptin may be shorter, for example, 6 months. And we know radiation therapy can be omitted in elderly patients with a smaller tumor with a low-grade negative lymph nodes, estrogen receptor positive, and HER2 negative patients who will have an endocrine therapy after lumpectomy. About 5 to 6% of new patients present with a metastatic disease, but eventually 30% will develop metastasis after initial diagnosis sometime later, most commonly to the bone, lung, and the liver. Unless patients have a symptomatic visceral metastasis like a liver or lung, endocrine therapy with or without CDK4/6 inhibitors is preferred. About 15% of new metastatic lesions have a different estrogen receptor or HER2 status, so biopsy of the new metastatic lesion is always recommended. The preferred therapy is combination of aromatase inhibitor and the CDK4/6 inhibitors. For premenopausal women, ovarian function suppression is added. We already studied about aromatase inhibitor, and the CDK4/6 inhibitors have 3 drugs available: palbociclib, Ibrance, ribociclib, Kisqali, and abemaciclib, Verzenio. Although these 3 drugs have a similar efficacies, they have a little bit different in terms of side effects and some functions. For example, ribociclib, Kisqali can cause abnormal liver function and the QT interval prolongation. Abemaciclib, Verzenio, particularly cause diarrhea. And the abemaciclib may be effective for brain metastasis. So when the patients present with a brain metastasis, consider to use abemaciclib among those other drugs. They always cause some neutropenia, more so with palbociclib and abemaciclib. And also patients complained fatigue. Overall objective response rate is about 50% with a combination of aromatase inhibitor and the CDK4/5 inhibitor. What if fulvestrant, which is selective estrogen receptor degrader, combined with a CDK4/6 inhibitor? It's actually a good choice if the patients cannot tolerate aromatase inhibitor. It has a similar efficacy, no significant difference in overall survival when compared with the aromatase inhibitor with the CDK4/6 inhibitors. Fulvestrant and a combination of fulvestrant and aromatase inhibitor is better than aromatase alone in overall survival, but other studies showed no difference in overall survival. Fulvestrant alone is better than aromatase alone in progression-free survival, but not in overall survival. Aromatase inhibitor alone was better than tamoxifen alone in terms of overall survival in a meta-analysis, but other randomized studies showed aromatase was better than tamoxifen only in progression-free survival, but not in overall survival, which published very recently. For premenopausal women, as I said, concurrent ovarian function suppression is necessary, especially when used with aromatase inhibitor. Also, tamoxifen can be used with ovarian function suppression. When progressed over the first-line therapy, or progressed within 12 months of completion of adjuvant endocrine therapy, then tumor is resistant to the endocrine therapy drug used. Then patients need to have different kind of endocrine therapy drugs or different treatments. But if symptomatic visceral metastasis, the treatment is urgent, then chemotherapy used first. When aromatase inhibitor monotherapy is used before, then fulvestrant with the CDK4/6 inhibitor's choice. When the tamoxifen was used before, then aromatase inhibitor with the CDK4/6 inhibitors. I'm trying to tell you that patients need to have a different medicine that was not used before. But if the patients already had a CDK4/6 inhibitors, then you need to test the tumor tissue or blood for PIK3CA mutation. About 40% of ER-positive, HER2-negative tumor have a PIK3CA mutation. When the liquid biopsy blood PI3CA mutation was negative, then you need to repeat it with the tumor tissue because the liquid biopsy is not as sensitive as test with the tissue. When the PIK3CA positive, then a PI3CA inhibitor, alpelisib, the trade name Piqray, is used in combination with a fulvestrant. The FDA approved with this combination of treatment. It's quite effective, and that I want to mention that the Piqray alpelisib can cause hypoglycemia. I even had a patients who have to be in ICU because blood sugar is over 500, 600 fluctuating, especially when they have underlying diabetes mellitus. You treat the hypoglycemia and just resume again when the blood sugar drop 160. Rash is common, but when the rash occupies less than 30% of body surface area, you don't need to interrupt the alpelisib. Just treat with the topical or low dose of steroid and the antihistamine. But if it's over 30%, you have to hold it and then treat aggressively. But if the rash is severe, bullous, exfoliating, have to discontinue alpelisib. When the PIK3CA mutation is negative, then you can use fulvestrant alone with or without everolimus. Later line therapy include tamoxifen with everolimus or abemaciclib alone or tamoxifen alone if they didn't use these drugs before. Tamoxifen with the abemaciclib didn't improve over survival over abemaciclib, so you don't need to use in combination, use it separately. Progesterone, estrogen, or androgen can be used. Chemotherapy is kind of a later line therapy. Single agent chemotherapy sequentially is preferred over combination chemotherapy. But if the patient have a symptomatic large tumor, then combination chemotherapy can be used. Most commonly, capecitabine oral chemotherapy is used. 2 weeks on or 1 week off, or 1 week every other week, especially for bone and the brain metastasis. Do you know this capecitabine is effective for brain metastasis? So consider to use capecitabine when the patients present with a brain metastasis. Other drugs include taxane, paclitaxel, nab-paclitaxel, docetaxel, or anthracyclines, or combination of anthracycline, taxane, and the cyclophosphamide. When the patient have BRCA positive, then platinum is added. The principle of treatment of HER2 positive metastatic disease is to use HER2 inhibitors in combination with a single chemotherapy or with endocrine therapy if hormone receptor is positive. And the combined use of two different kinds of HER2 inhibitors is quite effective and increasingly approved by FDA recently. Depending on the time of progression after the last HER2 inhibitor therapy, the treatment is somewhat different. If disease progressed beyond 6 months after the last trastuzumab or Kadcyla, THP is quite effective with the overall subjective response rate, 80%. THP stands for Taxotere, the docetaxel, and the Herceptin and the Perjeta. Taxotere can be replaced with a Taxol, paclitaxel, weekly for better tolerance. Kadcyla, trastuzumab emtansine, is also effective if it's not used. It's also effective for brain metastasis and causes less neutropenia and alopecia. When the chemotherapy need to be avoided, trastuzumab with pertuzumab or trastuzumab alone is an option. When the tumor is hormone receptor positive, HER2 combination and the endocrine can be combined if disease is not rapidly progressive. For example, Herceptin with or without Perjeta and letrozole or anastrozole. But if disease progressed less than 6 months of last HER2 inhibitor therapy, then in HER2, trastuzumab deruxtecan is quite effective. Of course, Kadcyla can be used if it's not used before. But in HER2 was better than Kadcyla in progression-free survival or overall survival. But in HER2 can cause interstitial pneumonitis, which is serious in 10% of patients. And the Kadcyla can cause serious bleeding, so you have to be careful when the patient is taking anticoagulants. When the patients have a brain metastasis, I have a good suggestion. Tucatinib in combination with capecitabine and trastuzumab provide a 2-year overall survival of 45%. This tucatinib is oral HER2 inhibitors. Recently, margetuximab in combination with the chemotherapy show the quite effectiveness and recently approved by FDA. Lapatinib is another oral HER2 inhibitors, can be combined with the trastuzumab, and this dual anti-HER2 inhibitor therapy is good for disease progression on trastuzumab alone. Liratinib is also oral HER2 inhibitor, can be used with capecitabine. If the hormone receptor positive, lapatinib, trastuzumab, dual HER2 inhibitors in combination with aromatase inhibitor improve the progression-free survival. And also abemaciclib, CDK4/6 inhibitors in combination with the fulvestrant and the trastuzumab improve the progression-free survival, recently published. As we discussed, the HER2 inhibitors include trastuzumab, Herceptin, pertuzumab, Perjeta, trastuzumab, emtansine, Kadcyla, trastuzumab deruxtecan in HER2, tucatinib, lapatinib, neratinib, margetuximab. And the duration of treatment for metastatic disease, chemotherapy used for 6 to 12 months, but HER2 inhibitors can be continued indefinitely. When used with the chemotherapy, the HER2 inhibitors are combined with a single agent chemotherapy, as I mentioned before, not with a combination chemotherapy. Treatment of metastatic triple-negative breast cancer depends on the PD-L1 score. If the combined positive score is 10 or above, immune checkpoint inhibitor pembrolizumab, Keytruda, in combination with the chemotherapy is quite effective and recently approved by FDA. the chemo regimen used with the pembrolizumab is either paclitaxel or nab-paclitaxel Abraxane, or combination of gemcitabine and the carboplatin given weekly infusion. Previously, FDA approved atezolizumab when combined with a paclitaxel for metastatic triple-negative breast cancer. But recent studies showed atezolizumab was not effective and there is no benefit when compared with the paclitaxel alone. So atezolizumab was withdrawn recently. When the PD-L1 score is less than 10, single-agent chemotherapy is preferred. But for the rapidly progressive disease, combination chemotherapy is also indicated, especially with the platinum-containing chemotherapy. As a second-line therapy, sacituzumab govitecan, Trodelvy, given weekly infusion, was approved recently. Sacituzumab is an inhibitor of TROP2, which is expressed in most triple-negative breast cancers. Of course, test for tumor mutational burden, TMB, and deficient MMR need to be done for metastatic breast cancer or all other solid tumor when the positive pembrolizumab is indicated. Many triple-negative breast cancers is associated with a BRCA, especially BRCA1, either germline or somatic, and also with a PALB2. When the patients have a positive BRCA mutation and the PALB2, then PARP inhibitors are preferred, olaparib or talazoparib, but beloparib is not approved yet. If they progressed on PARP inhibitors, then PD-L1 score is high. Combination of pembrolizumab and chemotherapy is the choice. But this combination of pembrolizumab and chemotherapy can be used as the first-line therapy, as we just studied just before. When the PD-L1 score is less than 10 and the tumor progressed on PARP inhibitor, then chemotherapy is the only option. Now, let's discuss hereditary breast and ovarian cancer, HBOC. About 15% of breast and ovarian cancers are caused by germline mutations of BRCA1 or BRCA2 genes. It is inherited in autosomal dominant pattern. Patients with a BRCA-positive breast cancer have a consistently increased risk of recurrent breast cancer in the same or the other breast. So many patients opt to bilateral mastectomy for the treatment of breast cancer, although breast-conserving therapy can be done. Patients who had a prophylactic contralateral mastectomy, in other words, bilateral mastectomy, had a better 20-year survival than those who had a unilateral mastectomy for breast cancer. Carriers of BRCA mutation without cancer have an increased risk of many different kinds of cancers. Of course, breast cancer, about 70% of them developed during their lifetime. Ovarian cancer, 20 to 40%. Male breast cancer is more common in the BRCA2 carrier. Cancer of fallopian tube, peritoneum, endometrium. And the pancreatic cancer risk is higher in BRCA2 than BRCA1. Stomach cancer risk is higher in a female than in male. Prostate cancer is only seen in BRCA2 only, and those prostate cancer are more aggressive. Melanoma and the other skin cancers are higher in BRCA2 only. So the patients who have BRCA2 carrier need to have a melanoma and the skin cancer screening. Biallelic BRCA mutation, in other words, BRCA carriers having two mutations, one from father, the other from mother, can have a Fanconi anemia, which is very serious blood disease like leukemia. So the patients who have a BRCA mutation need to have a genetic counseling before marriage to avoid those serious illness. How to manage those BRCA carriers who did not have a cancer. Prophylactic bilateral mastectomy decreased the breast cancer risk by 90%. Nipple or areola sparing mastectomy is fine. And many patients undergo recurrence-reduced bilateral salpingo oophorectomy. Those are prophylactically surgical removal of both ovaries and the tubes. It reduced the ovarian cancer risk by 80%, and it should be done by age 35 to 40 for BRCA1 or by 40 to 45 years for BRCA2 carriers. But the risk of primary peritoneal carcinoma persists, especially a serous tubal intraepithelial carcinoma is found in the resected tubes. The 10-year risk of peritoneal carcinoma is 28% when they have a serous tubal intraepithelial carcinoma. So women with BRCA mutation need to have a breast cancer screening. Clinical breast exam beginning at age 25 every 6 to 12 months. Of course, those women who did not have a prophylactic mastectomy. And the MRI breast beginning at age 25 every year. And the 3-dimensional mammogram beginning at age 30 every year. And it can be alternate with the MRI. Ovarian cancer screening for women without prophylactic bilateral salpingo-oophorectomy include a CA125 blood test and the transvaginal pelvic ultrasound every 6 months at days 5 to 10 of each menstrual cycle beginning at age 30. And the skin screening for BRCA carrier, because the BRCA2 increase the risk of melanoma or other skin cancer. For BRCA2 carrier only, tamoxifen is indicated as a chemoprevention. It reduced the risk by 62%, but not for the BRCA1 carrier because BRCA1 carriers are mostly estrogen receptor negative. The indications of BRCA testings are different depending on the organization. NCCN guidelines is most commonly used. The BRCA testing is indicated for breast cancer patients who was diagnosed at age 45 or younger, or majority of women age 46 or to 50s. And there are many other indications. Some other agents recommend the BRCA testing for all breast cancer patients. I don't know if it's necessary or not. I would like to introduce some new information about breast cancer. We know the BRCA carriers who did not have a prophylactic mastectomy will benefit from chemoprevention with the tamoxifen. But this chemoprevention is also indicated for other high-risk women who have a high-risk lobular carcinoma in situ, atypical ductal hyperplasia, or atypical lobular hyperplasia, or women who had a history of thoracic surgery a long time ago. The chemoprevention drugs used for postmenopausal women include raloxifene, tamoxifen, or aromatase inhibitors. For premenopausal women, only tamoxifen is used. It's good news that the same side arm of the breast cancer can be used for blood drawing, IV, or BP measurement as long as there is no lymphedema in that arm. The recently Society of Ambulatory Anesthesia and the American Society of Breast Surgeons issued that using the same side arm for IV phlebotomy or BP measurement do not increase the risk of lymphedema. What about pregnancy? Subsequent pregnancy after breast cancer treatment is safe. A study showed that subsequent pregnancy improves overall survival outcome. However, it's advised to wait for at least 2 years, and pregnancy should be postponed until the chemo drugs effects are ended. For example, 2-3 months after tamoxifen therapy was discontinued, or 7 months after Herceptin. Some patients ask me about circulating tumor DNAs. It's done by a blood test, liquid biopsy, to predict the early recurrence. I think it's a very interesting approach and has a great potential, but still there is no evidence of clinical validity and the clinical utility at present time. But I know in a few years we may use this method to predict the recurrence, and we already using to detect the targetable mutations. The 5-year survival rate of breast cancer patients who have a stage 1 is 100%, stage 2 93%, stage 3 72%, stage 4 22%. But this did not include the triple negative or inflammatory breast cancer. Those have a worse prognosis. But triple negative breast cancer mostly recur within 3 years of diagnosis. It is extremely rare to recur 5 years after diagnosis, so it's good news. Inflammatory breast cancer prognosis is not too bad. 5-year survival 30 to 70% after neoadjuvant chemotherapy, surgery, and radiation therapy. This is the view of the Rocky Mountains. I took this photo from the place near the Good Samaritan Medical Center where I'm working now. And I thought about Psalm 121. I lift up my eyes to the hills. Where does my help come from? My help comes from the Lord, the maker of heaven and earth. Indeed, he who watches over Israel will neither slumber nor sleep. The sun will not harm your body, nor the moon by night. May God bless all the breast cancer patients and help them to overcome their disease. Thank you for watching.